Well, hello and welcome to the August 2022 edition of Arizona Community Grand Rounds. My name is Mark Carroll, and I am with the Medicaid Health Plans at Blue Cross Blue Shield of Arizona, and it's my honor and pleasure to co-facilitate these rounds with Mary Jo Gregory, President and CEO of the NARB Institute. Thank you, Mary Jo. Today we have a great panel presentation on some emerging topics and some topics that have been with us for at least 2 years related to COVID, and have a fantastic group of presenters and experts in the field across Arizona that we're so fortunate to have in the state, working every day on issues like they'll discuss today, as well as with us today to help answer some questions. If you're new to rounds, please know that your mics are muted, but you're welcome to ask questions in the chat and Q&A, and we'll get to them as we can. These rounds are recorded and will be posted on the NARB Institute Arizona Community Grand Rounds website within the upcoming days at the conclusion of today's rounds. One last quick announcement is that rounds in September will focus on the important topic of climate change and what health professionals need to know. An announcement for that and the opportunity to register for that will be going out in the next day or so. We have a terrific list of speakers for that as well. Well, today's session is focused on key topics related to COVID and emerging infectious conditions. We are so pleased to announce the beginning of the Arizona Emerging Therapeutics Consortium, a collaboration of folks such as our panelists today and many of you that has been an extension from the Arizona Monoclonal Antibody Work Group, which was formed in early 2021 in response to the COVID pandemic and the use of monoclonal antibodies. So there's been lots of great participation. This Emerging Therapeutics Consortium is supported generously from the Arizona Department of Health Services. And we're so pleased to have the engagement of Dr. Bob Orenstein, his colleagues at Mayo, others on the panel today, and so many of you from across the state to bring life to this consortium as an opportunity to advance health equity related to the sharing of information and best practices regarding COVID and other emerging conditions such as monkeypox, which we'll discuss today. So I will now turn it over to Dr. Orenstein, Chair of the Department of Infectious Disease at Mayo Clinic, Arizona, to lead today's discussion. Bob, please take it away.
Great, thank you. And thanks for putting everything together to get us off the ground and start this Emerging Therapeutics Consortium. We hope that you will be able to cover a lot of different topics through the year and get feedback from all of you that are participating today and what ideas you might want to hear about, what topics, and maybe speakers that you think would be valuable to contribute to understanding things throughout the state and how we can best manage some of these emerging infections. Today, we actually have a great group of speakers. We're going to cover mostly COVID, a little bit about monkeypox, and if there's time left over, which I doubt, any other topics that you think might be of interest to you related to emerging infections. So let's get started. Our first speaker will be Dr. Dave Engelthaler, who is the director of TGen North. For those of you who've been on these calls in the past, you're well aware of Dave's expertise at TGen and helping us to sort out what's happening with the COVID-19 pandemic. So I'll turn it over to Dave.
Thanks, Bob. I'm going to pull up some slides and really focus on a quick background of where we are right now today with COVID, primarily about the virus and the current state of variants. Am I showing the right screen? Can you confirm? Yes, okay, thank you. All right, good. So yeah, I'll focus on the variants here and how that's really affecting both how we think about the vaccines as well as hopefully set up the conversation about therapeutics as well. Here's just the current state of epi. As we all know, we've been through multiple waves and surges. Arizona and the US are kind of mirroring each other right now. We're pretty much seeing, as you know, this big giant needle spike occurred in in the US, also occurred in Arizona, had really bottomed out after that. That's what that first Omicron wave hit us. That was in January, and really kind of went down to very low levels, and then started to creep back up again back in about May and June, and we started getting this plateau both nationally and certainly here in Arizona. It kind of crept back up and has plateaued now for the past almost 2 months, 2 solid months, hanging about the same level. The real question is how is this affecting the population and the healthcare system, and what should we do about it? And so one of the things we need to look at is really the serious outcomes on a population level. We know that as the cases went up, so did hospitalizations. And that's what we're seeing here. Most of these are people hospitalized with COVID rather than hospitalized for COVID. We can see this bottom line on the left-hand graph. This is the ICU usage in Arizona. And you can see that really dropped off after the initial Omicron peak. It's dropped off to very low levels and has stayed there. It is the lowest percentage of hospitalized cases since the beginning of the pandemic. So that is good news. We know that this has been after that first wave has been a much milder course. The virus itself is acting differently. We'll talk a little bit about that. And then looking at deaths, this is from the data that's come out today. We could see that we saw a slight increase in deaths occurring in mid-June to early July, and that's been dropping off too. We're now averaging about, I think in June we were averaging about 10 cases a day, and now we're dropping off to about 4 to 6 cases per day in Arizona, and that keeps dropping. So that, again, the lowest levels it's been at really since the beginning of the pandemic, even though we still have plenty of virus circulating in the community. And what is circulating is particular variants or variant now. As you know, we've been tracking the fact that the variants have changed quite frequently, and not just the variants, but now real important subvariants. What you see on the left-hand side, this is back October, November, and December. All that purple was the Delta virus and its variants that was circulating. And we really didn't see Omicron hit us until beginning of December, and then quickly actually became nearly 50% of the cases we were seeing. January became essentially everything that we've been seeing, and everything that we've seen since has been some version of Omicron. And that has been played out obviously on the national level too. Arizona is not different in this regard. And then we know that as it's really taken over in the last couple of months, we've been hearing a lot about BA5 that showed up back in May. And now what we're seeing is that it is really become dominant. And so if we look just within Arizona specifically, and hopefully you can see on here, BA5 is the reddish color. And yeah, since June, it became half of the cases, it has now become the dominant. We're probably over 90% of our cases today are this BA5 version of Omicron. So what does that mean? These different variants, and especially BA5, which is our dominant, we still see a fair number of the BA4 cases. Those are actually pretty closely related. And really what it is that we're seeing a different mutational profile with each successive subvariant of Omicron. And in this particular graph, sorry it looks so busy, and I'll just try to explain a couple of pieces in here. What we're looking at the top here is the spike gene and the different subcomponents of the spike gene. Importantly, the receptor binding domain of the spike gene is this whole segment here, and mutations in that could really affect, one, how the virus interacts with the host cell, but also importantly, how antibodies interact with the virus. And so any mutations in there could be important. We could see when BA1 showed up, and that's the original Omicron strain. So we're looking at purple and red here. All of these were really brand new mutations that weren't occurring, that we weren't seeing in Delta. So this new variant just came with a whole bunch of new mutations, especially in that all important receptor binding domain area. Then BA2 came along. That came up with a number of new mutations as well. In fact, BA2 seemed to be split off early from the BA1 or the original Omicron variant. And I'll show you a little tree here in a second. So independently it showed up quasi-independently, I should say, showed up and then started circulating as well with its own set of mutations, again, with some new mutations in the receptor binding domain. And then BA4 and BA5, which are circulating now, they don't have a whole lot of mutations, new mutations, but they do have some that are incredibly key that are changing the shape of the pandemic or the state of the virus right now. And so when I mention that we're getting an effect on antibodies, we can just look at neutralizing antibody. And so I'm showing this that recently came out of New England Journal. So this, again, busy, I'll just step through a couple things. We'll just look at the left-hand panel first. And this is looking at people who were vaccinated but didn't get a booster versus people who got a booster. And then seeing how their antibodies actually react to the different variants. So we can see when you got a vaccine without a booster against the original variant, we have it Washington here, but it's essentially the same as the Wuhan strain. We had a fairly high level of antibody response, but the vaccine was not providing much in the way of a good antibody response by itself to any of the Omicron strains. Just barely showing up there. And so therefore that vaccine by itself was fairly ineffective against Omicron, which is why we had so much Omicron hitting us all at once. Everybody was vaccinated, or large amounts of us were vaccinated, and it really wasn't doing much other than helping to prevent serious illness. But after you get a booster, again, against the original Wuhan strain, the vaccine worked really well, but we also got a good boost against the different Omicron variants. Again, these are BA1, 2, one of the BA2 strains, and then BA4 and 5 down here. Now, we look at this as showing up a lot more than before you get the booster, but it's nothing compared to against the original Wuhan strain. And in fact, BA5 had 21 times less neutralizing antibody response than against the Wuhan strain. So we know that this is BA5 has had a tremendous effect on the inability of the vaccine to prevent infections, which is why we see so many infections. Now, thankfully, they're much milder as a general course of infection, so we're not getting as many serious illnesses. But this is why we've just seen so much. Now, if we had people who were infected with BA1 or BA2 after getting vaccinated, much, much higher antibody response than we even saw with just the booster. Again, against the Wuhan strain seemed to be the highest because your initial response, the initial antibodies were from the vaccine against that really supercharges those antibodies, but still getting, again, higher antibody overall than we were getting with just the booster by having an infection with BA1 or 2, which is why we had so many cases early on and not as many now. However, we are seeing more and more cases than we should, even though people were recently infected just as little as 5-6 months ago from the original Omicron strain. And again, we look, even though we're getting some antibody response in BA4 or 5, it is still nearly 20 times less than the antibody response we get against the original strain, which doesn't exist anymore. So the virus we're dealing with now is being very good at evading our antibodies, however we're generating those. Just a couple more slides I want to hit on. One is just thinking about the fitness of this virus. We've talked about the survival of the fitness, how this is a natural Darwinian experiment happening in front of us. And it's very true. Just looking at this graph, and this fitness is a measure, it's calculated by a couple of things. One, its ability to replicate and its ability to spread in a population. We look at the original Wuhan strain here in the far left-hand corner. This is, essentially this is the original strain. We look at the relative fitness against that original strain. So that's listed as 1. When we had this a mutation occur early on in the pandemic called D614G that showed up in Italy and in France, and then that's what spread across the world. That was this particular strain, definitely higher fitness than the original Wuhan strain. And then there were a lot of different variants that popped out that actually weren't as fit, and they disappeared until we started getting what we called the variants of concern. We had alpha, which is this big circle, and beta. These were about equivalent to that first big mutation we had, but really spread quickly among the population. And then we had gamma, And then we had Delta, and this is the original Delta strain, much higher fitness. And then all of the successive Delta subvariants, all of these here, just a little bit more fit as it goes higher up on the y-axis. And then, so these are all the Deltas that were carrying us. And then all of a sudden Omicron hits, incredibly a higher relative fitness than anything we'd ever seen before. And successively, again, the variants become more and more fit, more easy to spread, higher replication, and the fact that they evade antibodies makes this virus we're dealing with today very, very different than the original pandemic strain that came out of Wuhan. I mentioned a tree just to show you, I'm not going to go through this whole tree, but if we look at the Wuhan or the Washington strain here, that's kind of at the center of this. And then all the variants kind of spread out from that. Omicron was its own variant on a branch that actually somehow started probably May or June of 2020, very early on in the pandemic, yet was just hanging out there and developing mutations, and then all of a sudden exploded around Thanksgiving of last year. And has developed then these successive variants after that. Is very different. And why does that occur? Well, we think what occurs is that these branches represent when they are secluded, likely in a patient with a long-term infection. What we talked about, chronically infected immunosuppressed individuals. And I'm not going to go through too much of this. This is just an example of one of those patients that we've actually looked at working with our cancer patients, our partners at the City of Hope. And this is serial sampling from a patient that was long-term infected of a strain back in 2020. And just looking each week, you can see as this goes down on the y-axis, each week looking at the mutations in the spike protein versus the original infecting strain. And it's a heat map, so it's the proportion of the viral sample in that patient. As it gets darker color on here, more and more of it has that mutation. We can see each week starts to pick up a new mutation showing up somewhere in that spike protein, till at the bottom, we have a whole bunch of new mutations that weren't there before after several months of infection. This is the type of an infection then that potentially, if it got into another patient, would be brand new and potentially spread and evade antibodies that wouldn't have been circulating normally in the population. That might make these chronic long-term infected patients the most important, maybe the most dangerous patients to maintain this pandemic carrying forward. And so this is what we think we see when we saw Beta, when we saw Gamma, when we saw Delta, and now Omicron, long-term infected patients picking up a whole bunch of new mutations. This is the only slide I'm showing on therapeutics. I'm not going to go through this detail, but you can see these different curves here represent different Omicron variants, except for the blue, which is Delta, against the different monoclonal antibodies that are out there. And you can see some of them have become less and less effective, and some actually become more effective, depends on the variant. So these mutations are critically important in actually determining the efficacy of our monoclonals, as we all know. My wrap-up slide, BA.5 and beyond. BA.5 is not a generalized threat to the community, but it is not the last of COVID. It is essentially what we're going to see is probably more variants coming out of this. I believe that the highest risk, given what we know about the vaccines, only the highest risk should be boosted with the current vaccine if they have it. The remainder, hopefully we're going to have a vaccine updated with BA.5 in the fall. That'll should give us protection, more protection against at least the most recent circulating variant. We do think it's on the right trajectory. It does have high transmission. There's no doubt about it. Lower infectious dose. It's mainly an upper airway infection, and it has antibody escape that's allowing for all this transmission. Lower virulence, again, being an upper airway infection, we're getting less and less of the deeper airway and systemic infections that we were seeing before. And this all makes evolutionary sense, not for it to become a milder virus, but for it to spread faster and evade immunity. And we don't know what's going to come next. Hopefully it's going to be BA.6, BA.7 in the fall and in the winter, and not Pi or Rho, which would be new variants that maybe just come out again out of nowhere with a whole new set of problems. All right, sorry, I took probably a couple more minutes I wanted, but I think that gives enough of a background. And I'll stop the share here.
Great, thank you for that great overview. And next we're going to have Dr. Sean Elliott, who's an emeritus professor of pediatrics from the University of Arizona. Currently works for Tucson Medical Center in pediatrics, and he's going to give us an update on some pediatric issues.
Right. Thank you so much, Bob. And I really appreciate the fact that Dave went first and shared the data, because as we see the different variants come through, that is also tied very tightly to how pediatric disease and risk of transmission of disease has also sort of migrated. Basically in the first days, first months, and even first year of the pandemic, with the alpha and the beta variants, we did not see a lot of pediatric disease, thank heavens, nor were kids sort of the smoking gun of transmission, such as they are with influenza and RSV and rhinovirus, enterovirus, et cetera. Unfortunately, though, that all changed when Delta variant came through, and we started to see a significant uptick both in severe disease, so children, adolescents being admitted with multi-organ disease, severe pneumonia, the onset of multi-system inflammatory syndrome in children, MISC or MISC, really sort of dated significantly to the onset of the Delta variant. And also, as one tracked sort of prospective population data, the percentage of new cases on a weekly basis that was pediatric climbed precipitously. So whereas before, 5%, 10% of all new cases, weekly in the United States, with Delta, that climbed up to 20, 25, 30, at a highest 33%. So a third of all new cases were children. Children up to age 18. And so that I think really unfortunately put pediatrics on the map with the pandemic, whereas before we've been sitting in empty hospital wards waiting for like the sky to fall. Fast forward to today with the Omicron, and as Dave mentioned, this is a phenotypic switch in presentation to an upper respiratory tract infection, very much like what we anticipate with other respiratory viruses. So influenza, parainfluenza, the rhinos, the entros, et cetera. And in that, children are still representing anywhere from 15 to 20% of all new cases, but they, like the adults out there, are showing up with milder disease. So the pandemic has shifted to much more of an outpatient or an ambulatory presentation. However, as I say that, I note that kids who have underlying comorbidities, just like adults, are still the ones who are being hospitalized. And as we speak with the BA.5 and some BA.4 around Arizona, there are several patients in hospital, in my hospital right now, with what we sort of euphemistically call the COVID croup. They're presenting with a croup-like illness, just like we expect with the parainfluenzas 3 and 1, and others are being triggered in their reactive airway disease to have oxygen requirements and bronchodilators, and just like all the other viruses which trigger a known asthmatic or patient with reactive airway disease into requiring hospitalization. So the pandemic is definitely not dead, nor is it resting in terms of pediatric patients. What has changed, as well as that change to an upper respiratory illness, thankfully, has also been the onset or risk of the post-infectious MISC, the MISCs. Those patients who had the multi-system inflammatory syndrome were really a large contributor to the not just morbidity, but mortality, the death rate of this pandemic for children. And we had several children, adolescents, who unfortunately expired of complications from their MISC here in Arizona. Yeah, it's only a handful, but the threat of that occurring drove a significant amount of angst and evaluation and hospitalizations and ER visits, just due to the wish or the threat of trying to avoid MISC. Fortunately, that illness has dropped off the map after the onset of even the original, the BA.1s and 2 Omicron strains. So that's good. That's great. That's wonderful. However, I think we're always looking for threats and hidden corners. And as we see more PEDS patients now again admitted with what we assumed to be the BA.5 based on the bioepi that Dave shared, we're again seeing a phenotypic change once again in the presentation. More pediatric patients and also, as I understand from my adult colleagues, adults as well, are presenting with a GI presentation. So much more of the vomiting, some diarrhea, the fevers, along with some respiratory illness. And it makes sense, I think, both teleologically and immunologically, that as those mutations occur and affect binding sites in the spike protein or targeting of the virus to its ACE2 receptors, that a different tropism may emerge as that antigenic structure also changes. So it may be that we're now starting to see more GI epithelial cells get targeted than before with the early subvariants of Omicron. And as that happens, that of course makes me concerned that a new immunologic reaction may again emerge, and we may yet start to see more MISC cases. So certainly in the pediatric side of things, I think things have amped up in terms of what's out there clinically and risk for clinical disease. Perhaps I think even more importantly, because I'm still talking a relatively small percentage of cases, is the finding that pediatric patients now have become, by and large, the index patients in new clusters or outbreaks. Early days of the pandemic, as I mentioned before, it was adult patients affecting their children at home, not the school kids bringing home virus from school. And unfortunately, that has now changed, again, really starting with Delta variant and continuing through to today. So today, it is far more likely than not that a new adult case actually acquired their infection, unfortunately, from a child either in daycare or school or sporting event or something, who brought home, our dear friend SARS coronavirus 2, potentially in an asymptomatic way, and shared that little gift with adult care providers, family members, friends, et cetera, and so forth. So in that regard, then, that the pandemic has really come to represent that which we expect every year with an influenza epidemic. School kids are the source of this, and they bring it home and share it with families, and then the families lose work because they're homesick as well. That I think is a very important point to hammer home, especially to our patient population, as we enjoy now the benefit of vaccines available, COVID-19 vaccines available for all ages 6 months and up. And that has been a dramatic development in just the last several months or so, where both Pfizer and Moderna released data from their mRNA vaccines in children ages 6 months through 4 or 5 years, respectively, and found that there was efficacy, there was protective status, there was safety, et cetera, and so forth. And so fairly rapidly, FDA and followed by CDC, and Director Walensky gave approval to both mRNA vaccine products. So we can now use one or the other for every child ages 6 months all the way through to 18 years of age for pediatrics. Fantastic, right? We've been pushing for this. The AAP has been lobbying for this. There has been extensive dismay and wailing and gnashing of teeth about the delay in getting both the studies and the safety confirmation and the emergency use authorization. And when it finally occurred, it's almost as if it occurred in a vacuum. The predicted huge rush to get every child vaccinated 6 months and up never materialized. And so data released just several weeks ago from national trending organizations are that of all the children of vaccinatable age, so 6 months and up, but especially looking at 6 months through 5 years age, only 1.3% of those potential recipients have received at least one dose of vaccine. Not even completed vaccine series, have received a single dose. That's abysmal. That's horrifyingly abysmal. And it's not for lack of trying and support and education and everything else. And of course, a lot of individuals trying to discern like what are the obstacles. And it really has to do, I think, with both pandemic fatigue and also the perception, valid or not, that COVID-19 is now a survivable illness with minimal impact. And it's just like every other respiratory virus out there. So you get it, you're sorry for yourself for a couple of days, and then you get better, and that's the end of that. And I think to a certain extent that may be true with the Omicron variants. But that doesn't mean it's going to stay true. And as Dave was sharing, I worry about what happens with upcoming sub-variants, 6 or 7 for Omicron, or if heavens forbid there's a much more significant mutational event or an antigenic shifting event, which gives us, something subsequent. Pi, I think, is the next one up. So it's not as if we're completely over this thing, and yet the perception by families, parents, and even providers, unfortunately, is that there is minimal risk, and it's hard to justify a vaccine product which, yes, is brand new to the market, and its safety studies are no more than a half year old. Doesn't mean it's not a safe product at all, just that people are afraid of the newly tested product. My suggestion, my answer to those individuals when they ask, why should I proceed with vaccinating in pediatrics, is exactly that point I just mentioned, which is kids are the ones and the major reason for the further propagation of this pandemic. Or if you will, the entry into endemic phase is going to be continued by the pediatric patients who bring home that infectious gift and share it with everyone around them. So I think we have wonderful responses, and certainly also, as Dave mentioned, the new BA.5 or Omicron specific vaccines currently in development and testing represent yet another wonderful step forward, and to me, a fabulous proof of concept for the impact that the clinical significance of an mRNA vaccine, which is so nimble. All right, here's your genetic code. Let's create that. Let's insert it, and away we go. So that's fantastic. But I think we're rapidly running out of interest in pursuing further vaccine, and we may be faced with what we've got right now as the foreseeable future for the COVID-19 endemic phase, if you will, unless we can effect a change somewhere else. Education, recruiting partners, and just trying to move things forward. So the concerns about re-entry to school, as at least in Arizona, school districts open up this week for return to school for many of our kids. There are still a whole bunch of disease out there, and I predict that as schools open up and students return, that we will see a following steeper increase in the surge of cases that was shared just previously from Dave and TGen. So I expect that we will see more Omicron BA.5s and 4 cases now in the families of our school kids as they return to school, with only a handful of schools planning to maintain mandatory masking. So it'll be interesting to see if the numbers reflect that anticipated reality. But I think we all share our concerns epidemiologically about the impact of the return to the school year. And I will sort of just get my 2 cents in about monkeypox in pediatrics. Thankfully, that's not a huge issue yet, although there are the first 2 pediatric patients confirmed in the United States, a toddler in California, a baby in Washington, D.C. Again, tip of the iceberg. I imagine that if we have time to talk about monkeypox, that the epidemiology will shift from the MSM, men having sex with men population, into more of a direct contact and non-sexually associated transmission, and thus I anticipate we'll see more kids out there. But so far, not yet, and just keep my ears open. So with that, I will pass the con back to Bob, and thanks all for inviting me to join you.
Great, thanks for that review and updating us on the changes going on in the pediatric world, which at least those of us who do adult medicine don't hear much about. The next speaker is Dr. Nick Staab from the Maricopa County Public Health Department. Nick is a medical epidemiologist and in disease control there, and I think Nick is probably working 24 hours a day, every day of the week. So let's hear about what you're up to.
All right. Thank you very much for having me. It's a nice hour-long break away from our monkeypox response. So thank you for that. I do have some slides, so I believe I can pull them up for.
They are up already.
Are they up? Okay, thank you. Perfect. Next slide, please. So Dave looked at the for COVID-19 at the epi curve nationally. And here in Arizona, this is the Maricopa County specific epi curve. And as he showed, we are just kind of in this stalled plateau. we believe that obviously the number of cases are much higher than what are reported to us in public health and demonstrated here on this epi curve because of the large number of home tests that are being done and not reported to public health, as well as just COVID fatigue, which has been mentioned. And so we expect that this is much higher. It'd be interesting to see if it is higher at a plateau as well, or if it tends to be peaking, but we are only detecting this plateau. So everything that was described about BA5 fits with what we're seeing on this epi curve, and again, puts us in what we feel like with vaccine administration and everything else, a kind of a precarious point in time as we get back to school and other activities that are going to bring people closer together during the fall. Next slide. And again, we do kind of look a little closer over the last 60 days, but we, again, are not seeing much of a change here from this plateau level. Next slide. And so when you look at the CDC's COVID community level, this is the level of community transmission that takes into account not only the 7-day case rate, but looks at those hospitalization metrics. So while we have not been seeing as many patients hospitalized or as severe disease with BA5, our numbers are still high enough that it puts us in this high community transmission. And again, we have seen over the last couple of weeks that both the case rate and the percentage of hospitalizations due to COVID-19 has just not changed much. And so we're just stuck here in this high community level. Next slide. That high community level comes with our public health recommendations, which are to wear a mask indoors when you're out in public. When we went from medium to high a few weeks ago, we did get a fair number of requests for interviews. I was on a lot making this recommendation that individuals pull out those masks, put them on, but your experience is probably very similar to mine. There's not a lot of masking going on out there. There's not a lot of interest in staying up to date on COVID vaccines, as I will show you in a moment here. And then again, testing, while it has been more popular in the past, certainly just not the same interest there in getting tested. And that may be due to people having less severe disease and just not feeling the need to test and then appropriately isolate. So again, it doesn't look like based on the mitigation efforts that are going on in the community right now, like we'll see a significant change in those levels here in the near future. Next slide. This looks like Dave's slides, but these are Maricopa County specific data showing BA5 making up about 77% of cases recently. Next slide. And here's our vaccine status, which again is unfortunate. That number there in the middle shows that only about 18% of Maricopa County residents are considered up to date, so having received their booster doses. So I might have a slight difference of opinion with Dave. We really are trying to encourage individuals who are eligible for that booster dose to get that booster dose, just because we are not exactly sure when that bivalent updated BA4 or 5 specific booster is going to be eligible. We hear a lot of different news, but again, we're just trying to, from a public health perspective, get as many people out there, get vaccinated and stay up to date on vaccination as possible. Next slide. And the new game in town is monkeypox. So we are, as of the 2nd, so our numbers reported yesterday at 74 cases here in Maricopa County now, 80 cases being reported in Arizona. There's been some discrepancy in the reporting getting up to CDC, so that number is not always aligned with ADHS in Maricopa County. But we do do a daily update of our numbers Monday through Friday on our county website. Next slide. This is the epi curve. So again, keeping in mind, as with any epi curve, that the most recent dates will tend to adjust up in time. So we are seeing what feels like a pretty significant increase over the last 2 weeks in the number of cases that are being reported to public health and being tested. Next slide. We do have Jynneos vaccine here in Maricopa County. We are supporting not only Maricopa County, but the other counties in the central region. That's kind of the plan for monkeypox therapeutic distribution, is to kind of go out to a northern, central, and southern hub, and then create other distribution mechanisms beyond that. Of those 3,000 doses, we've administered just over 2,000. I have plans to administer 500 more doses this week. We were able to put in an order for 3,500 additional doses that we're hoping we have by the end of this week to satisfy our planning moving forward. Again, this is a 2-dose vaccine. There has been planning assumptions to hold some supply for that second dose, but there are other jurisdictions around the country that have recently announced that they will be prioritizing first doses over second doses. So actively discussing in our response kind of what our plan is over the coming weeks. Those vaccines are being used for post-exposure prophylaxis for individuals who are known contacts of monkeypox cases. There's also expanded PEP or PEP++, and that is for individuals who are likely to have been exposed based on their activities, but not necessarily to a known case. So we are doing both of those currently with our vaccine. And the best way for individuals to be updated on vaccination opportunities is to fill out our vaccine interest form that again is on our website as well as linked here. In that form, they briefly identify whether or not they are high risk or if they are a known contact. That kind of puts them in different communication buckets. But again, as the supply of vaccine allows, we will expand the availability and then eventually beyond expanded PEP to include pre-exposure prophylaxis. Next slide. On our website, this is kind of how we have been prioritizing that PEP++. And so this individuals who fit these criteria are included in that specific communications. And then we are providing vaccine clinics, both at a where we're able to schedule people into those spots, as well as just have walk-in events. Our last walk-in event last week, we gave just over 1,000 vaccines in 3 hours. The demand is very high. And people tend to be giving us good feedback, but obviously because we don't have an abundant supply, some people are not getting their vaccine. So we're hearing from both sides of the aisle there. Next slide. And then the other therapeutic that we're busy trying to figure out how to get out and how to prescribe is tecovirimat or TPOXX. So this is both an oral and IV antiviral available under EAIND through FDA for monkeypox. We currently in public health have a supply of oral TPOXX on hand. We have a system currently where we dispense that from our public health pharmacy to directly to the prescriber, and that prescriber gives the medication to the patient. That's in part to ensure that an extensive amount of paperwork that's associated with the EAIND is being completed by that provider before the medication is dispensed to the individual. We are in talks with our healthcare systems locally and in practices, specifically those practices treating STIs, HIV. We're seeing a lot of these patients trying to get supply of tecovirimat directly to them just to expand access and ease of not running everything through our public health pharmacy, which was never the intention of that public health pharmacy. So we're also talking about getting an IV formulation specifically out to our hospital systems so that they would have that supply should they need it. And then, as Sean mentioned preparing for the inevitability of pediatric cases. A few more pediatric cases were announced yesterday. I forget exactly where they were, but in addition to the two that Sean mentioned. So it is, the situation is changing. Again, our communication about risk is that the risk to the general population is low at this time, but again, anyone can get monkeypox. And so again, with schools coming back, not only are we worried about the spread of COVID-19, but the inevitability that there will be exposures to monkeypox in schools and preparing for that. The indications for TPOXX treatment, I linked to a CDC document here. Happy to talk to any individual prescribers or physicians out there who want more information about that. And I believe that is the end of my slides. So thank you very much. And I will stop there.
Great. Thank you very much for that review, and thanks for covering monkeypox on such short notice. I'm going to share my screen. Hopefully y'all can see this. So what I'm going to try to talk about briefly today is a little bit about some of the Paxlovid controversies. Already there was one question in the Q&A about the effectiveness of this. So I thought I'd go through a little bit about Paxlovid and talk a bit about the rebound phenomenon. So the initial data on Paxlovid came from a new drug application filed by Pfizer, where they were able to show that if you took this drug for 5 days shortly after the onset of symptoms, depending upon if it was 3 days or 5 days before or after symptoms, you reduced the risk of hospitalization or death by about 87.6% in adult patients that were at high risk. And remember that in this trial, these were people that had not been vaccinated. So that's a little different than what we're currently seeing today in the people that are taking Paxlovid. And also there was data from a study in Israel that showed, again, similar data on reduction in hospitalization and death rates in the vaccinated and unvaccinated of patients over 65, but not in younger adults. So Paxlovid was approved for emergency use in December of last year, and the rate of prescriptions for this drug has gone through the roof, about 160,000 prescriptions being written per week. And as of, I believe, a week ago, more than 1.6 million courses had been administered in the United States, and still it's felt that it's being underused. What is Paxlovid? It's a combination drug. The active drug is the nirmatrelvir. That is an agent that interferes with the major protease of the coronavirus, and it prevents it from cutting the long precursor into shorter pieces. And it is effective against all of the variants that we've seen, which makes it a very useful agent for treatment in those that require treatment. What about some real world data since these drugs have come out? This is data from Hong Kong in an observational cohort of over 40,000 patients. About 2,000 received molnupiravir, which we use very little of in the United States, and about 1,000 patients receiving Paxlovid. And this drug, again, pretty much performed as was shown in the clinical trial, with a reduction in the risk of mortality and the reduction in risk of hospitalization. But it appeared, as is also known from the earlier trial data, that Paxlovid seemed to be a bit more effective than the molnupiravir, as molnupiravir was associated with longer hospital stays also in the surviving patients. What about in Israel? Well, in Israel, in an observational retrospective cohort, again, this one done during the Omicron dominant era, which is different than when the drug was originally studied. The therapy was associated with a 67% reduction in hospitalizations and an 81% reduction in mortality in patients over 65. So again, pretty much showing that this drug is effective at doing what it was designed to do, which is to reduce hospitalization and mortality in those at highest risk. Well, what about the elephant in the room? Well, the elephant in the room is rebound. And this was reported early on by several clinicians in the Boston area and has now become widely reported by many clinicians throughout the US. And CDC had issued an advisory back in May about this rebound phenomenon. And what this rebound was either developing recurrent symptoms after recovery about 2 to 8 days later, as well as those people that were testing negative who were then found to have positive results, particularly on antigen testing as opposed to PCR, which we know sometimes will remain positive for a prolonged period of time. Well, some of my colleagues at Mayo tried to look through a bunch of cases using the data that we had collected. They looked at 483 high-risk patients treated with 5 days of Paxlovid and really only found a small percentage of them developed rebound, about 0.8%. And all of those patients recovered quickly without any additional COVID-directed therapy. Now, this study is a little different than most of what's being reported from other centers. And this is a study that actually is very nicely done by a group at Cleveland Clinic, where they looked at rebound with both the Paxlovid as well as the molnupiravir. And they looked at 3 different outcomes, either rebound infection, rebound symptoms, or hospitalizations. They looked at 2 time points, 7 days and 30 days after treatment. And you can see pretty much what's been reported mostly in the press. About 5% of these patients would develop COVID infection. Somewhere between 2 and 6% develop recurrent symptoms. But again, hospitalizations and morbidity associated with this remain very low, 0.44, 0.77%. For molnupiravir, these rates are actually a little bit higher. So I know everybody calls it Paxlovid rebound, but this is being seen as well with molnupiravir at actually a little higher rate. And when you do propensity score matching, it doesn't appear that there's much of a difference between these 2 agents as far as risk of rebound. But what's been seen in all of these smaller studies that have been reported is that those that are older and have underlying conditions seem to be more likely to develop this rebound phenomenon. So what are the mechanisms? Early on, there was obviously concern that this might represent resistance to the antiviral drugs. Thus far, that has not been the case. A second hypothesis, which seems to be maybe more plausible, is inadequate drug exposure. Remember, these are only be given for 5 days. And if you look at the curves of viral concentrations in the upper respiratory tract, that's about the peak of virus in the upper respiratory tract is occurring at day 5. So if you were to start really early, perhaps you haven't given enough drug to allow clearance of the virus. And then other people have said, well, this is just the natural history of the disease. You know, we know that people rebound even when they aren't treated. What about resistance? Again, really rare. A couple mutations have been described in Paxlovid at these positions at 50 and 166 predominantly, but not been found really in these patients that have had rebound. I'm going to skip this one. So is it just the natural history? This data just came out today from the ACTIV-2 trial. ACTIV-2 was a study looking at a variety of different treatments and had a placebo arm. So they were able to actually look at the placebo arm and see what happened with the levels of virus in the upper respiratory tract, as well as symptomatic rebound. And what they found in this trial was 12% of the placebo recipients cleared the virus and then had viral rebound. And they found the same thing, that the viral rebounders tended to be older than the non-rebounders, although older in this group was a median of 54. They also found that a significant number of patients developed symptomatic improvement and then would go on to develop worsening symptoms later in the course of their infection. even in the absence of any antiviral therapy. Then they tried to look at high-level viral rebound in the upper respiratory tract after initial improvement, and they found about 1 to 2% of those individuals untreated had a high level of viral rebound in the absence of treatment. So their conclusions from this data is that viral RNA rebound or symptom relapse, even in the absence of antiviral treatment, is common, but the combination of the two is relatively rare. So what about using Paxlovid to prevent infection? So if you were exposed and maybe your family member had infection, should you use Paxlovid there? This study suggested that there really did not appear to be a significant benefit, although it did decrease the risk by about 1/3. When you compared it to placebo, there was no statistically significant difference between the Paxlovid and the non-prophylaxed arms. As I mentioned earlier, really no benefit in giving Paxlovid to healthy people that don't have multiple risk factors, so you probably should avoid prescribing it. And then lastly, I wanted to talk about who actually is getting this Paxlovid. I know at our place, numerous people from our medallion group were calling as soon as this drug became available. They wanted to take it with them on their trips. They wanted to have it handy just in case. And so it raised the question of whether Paxlovid is really going to the appropriate people that are at highest risk and are associated with the greatest morbidity. So interestingly, CDC actually looked at some of the data that they had of about 1 million prescriptions for antiviral pills given between late December and May. And they found that dispensing rates were lowest in the group that you might anticipate, those that were most socially and economically disadvantaged. And this is a nice graphic that illustrates those that received the drug and those in different groups of social vulnerability based upon zip code. And you can see the high group here. If you're high vulnerability, you are less likely to actually get the drug. If you're in the low vulnerability group, these are the patients calling me asking for Paxlovid. Many more of them actually were treated. So it does continue to raise the issue of health equity, even with antiviral therapy, as we saw with monoclonal antibodies, as we've seen with vaccination. This continues to be a challenge for us in managing people with COVID-19. So with that, I'll stop and I'll open up for anybody that has questions.
Dr. Orenstein, there was a question regarding Paxlovid for at age levels. Maybe this is for you or Dr. Elliott in terms of use under age 18.
I guess I can answer that it's not approved for that age group. I don't know whether people have been using it in that age group. Are you aware of that, Sean?
I'm not. I mean, it's technically approved ages 12 and up, but more importantly, body weight of 40 kilos and up. Just similar to the monoclonal antibody approval construct. But we just don't have that many kids who are sick enough to need it. And it really has not been considered, honestly.
There were a couple of other questions that were answered during the presentation by some of our panelists related to screening of wastewater for COVID. There's a significant amount of wastewater screening that's going on around the state, county, schools, and other institutions. And additional questions. If you have any, please feel free to pass them along to me, and I can forward them if you have them to our specialists and our panelists today. Dr. Orenstein, I think we've come up against our time at the hour, as you had predicted, lots to talk about and never enough time. So we'll have to continue to have this conversation moving forward. I'd like to just thank, on behalf of the Arizona Community Grand Rounds, again, for the leadership of those on the panel and other participants today and the engagement for the Emerging Therapeutics Consortium. Please send your ideas about ways that consortium can be more meaningful and meaningful related to equity issues. As Dr. Orenstein mentioned, equity issues are so important for us to not just be aware of, but to have collaborative responses to and proactive approaches, working in partnership to accomplish equitable access to information that leads to equitable access to therapies. With that, we'll close today's Arizona Community Grand Rounds. Reminder, next month, the topic will be on climate change and human health. And please look forward to announcements related to continuing conversations that may and likely will occur outside of Arizona Community Grand Rounds for the Emerging Therapeutics Consortium. I'm Mark Carroll. Thanks for joining today. Thanks to Drs. Orenstein, Elliott, Engelthaler, and Staab for your expertise, your amazing commitment to Arizonans and what you do every day. Take care all.